Thank you for joining us for another session on the use of endoscopy within neurosurgery. We're very honored and fortunate to have three real stars and pioneers in the field of endoscopy for the skull base and the brain, as well as regions around it. To not waste any time, I'll introduce our two speakers and our panelists. We're very fortunate to have Alberto de Soma here to moderate the entire session and help us guide the discussion about this new and exciting topic. Probably the originator, at least in the US, of this type of approach is Chris Moe, and he'll be speaking to us about really the origins and the organization of transorbital endoscopic approaches, and then talk about those approaches to the orbit. And then finally, Dusik Kong, who I think has really become a leader in this field, will discuss areas like Meckel's cave, cavernous sinus, and even brain surgery. So without further ado, I'd like to welcome everybody to the next session in this webinar on endoscopy and turn things over to Alberto. Thank you very much.
Okay. So, Dr. Moe, you want to go ahead with your presentation?
Sounds good. And can you see that?
Okay, great.
Okay. Well, actually, good morning, everybody. It's 1 o'clock for Alberto and I'm in a hotel room, so I apologize for the marginal optics. But I'm going to be talking about transorbital neuroendoscopic surgery and give you a very brief overview on it. These are my disclosures. I won't talk about anything except the book. We use some illustrations from. So my main career interest has really been minimally disruptive surgery, taking large open approaches and shrinking them down into smaller, minimally disruptive procedures. Well, as you see in this illustration, the orbits are centered near critical access areas such as the anterior cranial fossa, middle cranial fossa, even the posterior cranial fossa, and the paranasal sinuses. And in fact, the orbital roof occupies over 80% of the anterior cranial fossa, and the lateral wall is over 25% of the middle cranial fossa. So these give us some interesting possibilities. Well, it turns out that similar to endoscopic endonasal surgery, we can use the orbit as an optical cavity or a pathway to deeper structures. When I started thinking about these things, I went into the lab for about 5 years and worked on some clinical studies as well. And in 2010, I published my first series on that. And basically, the system includes an approach for each of the 4 quadrants of the orbit, and these can be used alone or in combination. And as you can see here on the upper left, we can work in the orbit, we can work through the orbit on the paranasal sinuses, or we can go through the orbit into various regions of the skull base and brain. Well, why would we do transorbital surgery? These are the endoscopic approaches that I use. Quite a bit of them, and a lot of variety. So how do we choose that one? Well, an ideal pathway is safe and easy and actually enjoyable. It should be short, so there's the least possible dissection. It should be straight because we're not operating around curves typically. There should be minimal brain retraction, and it should be minimally disruptive, allowing rapid recovery and return to lifestyle. So this is the most common approach that all of us use in skull-based surgery, a transnasal approach, and it works very well for the majority of cases. But one of the problems is what I call the narrow funnel effect. It's difficult to get your instrument and the scope separated. There's also a problem that when you're operating around an angle, just because you can see around the angle doesn't mean that you can instrument around that angle. And this is what I call the challenge of biplanar surgery. It's difficult to transition planes. So instead of biplanar surgery, I think it's better to do what I refer to as coplanar surgery, where the target, the approach, and the portal are all on the same axis. There's another problem, and that is if you operate with the scope and the same vector as the instrument, as you see on the lower left, where we're going up into the frontal sinus, you can't actually see the tip of your instrument. And that can be a big problem, particularly if you're doing optic nerve decompression. So if we use this transorbital approach to actually view, now we can see the tip of our instrument, which to me means we're going to be more effective and safer. And the other issue that's really great is by combining approaches through the nose, through the orbit, and actually in transoral and other approaches, we can do what's called multiportal surgery. One of the nice things about multiportal surgery is we can get multiple perspectives on pathology. And as you can see from this illustration, different objects can appear grossly different comparing on what the perspective is that you're looking at that. There's also an issue called the parallax effect, and it's that closer objects appear to move faster than objects in the distance, as you can see here. And this gives an idea of depth perception. And so by using more than one portal, we can use the parallax effect. And I'm going to show you here in a tumor, it's an osteoblastoma, and we're using quadruportal bilateral transorbital approaches and 2 transnasal approaches. And as you can see here, when we're instrumenting through both orbits and we're viewing through the nose, you have a great deal of separation between the instruments, and you can really see the tips of the instruments working. The other thing is you can move a suction up so that it's right close to your drill, so it's less, it sprays the scope less. And then finally, you can use it to look across the skull base and assess your reconstruction. And this is what that patient looked like 2 months post-op, symptom-free. So as I mentioned, there's one or more portal for each quadrant of the orbit. And I can't go into them in depth, but as you can see here, for the right orbit, to get to the upper quadrant, we use a blepharoplasty approach. To the medial quadrant, we use a precaruncular approach, which goes directly onto the lamina. Inferiorly, we do a direct inferior fornix approach, and laterally, we do a canthotomy and cantholysis or an upper blepharoplasty, or we can incise behind the canthal tendon, as you see here. And this is a larger magnified view of that. And these are all described and online, and you can email me if you want references. And all of these approaches are very brief, 5-10 minutes or so. It's critical to preserve the eyelid supports, and this is the way I look at it. The levator muscle and aponeurosis raise the upper eyelid, as you see here, and then the medial and the lateral canthi hold them laterally into position. So it's really important to study those and understand how not to damage them. And this schematic just shows how each quadrant will lead you to different areas in the brain. So what I've done here is I removed the orbital contents, and I've removed a significant amount of bone from each approach. So here on the lateral approach, you see infratemporal fossa, temporal lobe. The superior approach, you see the frontal lobe, and you can see the optic nerve as well as the superior fissure. Medially, we can see the where the optic canal is, and as it extends medial to the carotid artery and goes into the suprasellar region here. And in the floor, you can see back into the maxillary sinus into foramen rotundum very nicely. And this shows one of the topics Dr. Kong is going to be talking about as we go deeper back into the middle cranial fossa, looking at Meckel's cave and the lateral aspect of the cavernous sinus. Well, this can also be used, of course, for orbital tumors. And this is a woman, I apologize, I seem to have left my slide that has better densities. But here you see a recurrent adenoid cystic carcinoma, and she's already blind on the left side, but it's encroaching up the optic nerve, so we wanted to save her vision. So we go in from a contralateral precaruncular approach across the skull base, and then we start removing tumor off of the dura and the orbital contents. And once we've done that, you can see the orbital apex decompressed, the optic nerve decompressed going into the dura, the cavernous carotid and optical carotid recess. And so this is the panoramic exposure you can get without significant retraction on the eye. Now, these orbital approaches work very well for intraconal and tumors, particularly when they extend significantly behind the equator of the globe. And very importantly, if reconstruction is going to be needed. So if you're going to have to reconstruct after a big resection like this, you do it through the same approach, and you can use computer navigation. You get an extremely precise reconstruction, as you can see here. And this is just another example of it, but this is a 3-quadrant osteoma that's in the orbit, including the superior rectus, the superior oblique, and the medial rectus going through the frontal sinus into the brain. And we remove this transorbitally, as you can see here. 5 days post-op, he looks like this. 3 days post-op, the edema is gone. He said he never had diplopia and never took pain medicine for this. Well, one of the most common questions I get is transorbital safe? Well, these pathways are 3 cc's, whereas the total orbital volume is 30 cc's. So these are quite small. Furthermore, the globe is retracted less than 1 centimeter, and the optic nerve has a centimeter redundancy. So you can displace the orbital contents easily, but it's critical to monitor the pupils to make sure they aren't dilating. Now, the majority of the orbit is quite safe to operate through until you get to the orbital apex, and this is the danger zone as you get around the superior fissure and the optic nerve, and so there you have to proceed very carefully. And a critical thing is when you're retracting the orbital contents, the retraction has to be tangential. You can't push the retractor posterior to the globe here because the ciliary ganglion is back there, and you can get optic pupil dilation as you see here, but you can also damage the optic nerve or the retina. So endoscopic orbital and transorbital surgery is very similar, as I said, to transnasal surgery. You can use the orbit as an optical cavity, or you can operate through the orbit, and the optical cavity may be in the middle cranial fossa. And you can see when doing this, there's almost no retraction on the orbital contents, and that's one of the reasons why it's so safe. Clinical applications, you can see all these that I have in a list: orbital tumors, brain tumors, cavernous sinus pathology, getting to the trigeminal ganglion, seizure surgery, aneurysms are also starting to be operated on. So very exciting stuff. The outcomes of the world literature support the safety. Houlihan did a meta-analysis and found that the complication rate overall is consistent with other techniques, and all the complications, nearly all, were transient. And we're now working on a combined study of the incidence of CSF leak, and it looks like it's going to be near or less than 1%. There was a case of retinal hemorrhage reported, but this is due to the retraction phenomenon that I mentioned to you earlier. So back when we started in 2010, there was very little going on, but then international groups joined us, and Alberto and Keem and Dushik, and now everything's just snowballing and really taking off, and we have a book on the subject. So it's a really exciting time to be in this. So now looking back, why do we choose orbital surgery? Well, it's the least disruptive pathway for appropriate pathology. It's short and straight, there's minimum bone removal, and there's comfortable instrumentation through 0 or 30-degree endoscopic viewing. The optical cavity, which is your workshop, is excellent through these approaches, and the multi-portal technique can provide parallax depth perception as well. As you're aware, there's minimal brain retraction, and all these lead to minimal ICU stay at a very rapid recovery. So I want to thank you very much for your time. Please join the Endoscopic Transorbital Society here at endoorbit.com. It's free, and you'll see lists of upcoming meetings such as this one in Hong Kong in November, and feel free to email me if you have any questions. I appreciate the attention.
Thank you so much, Dr. Mo. Wonderful presentation as always. So we will save time, skip questions and discussion at the end. So if Dr. Dosi Kong would like to start your presentation at 10 minutes, and then we will move for case discussion.
Yeah. Can you see my slide?
Yes,
Yes.
please go ahead.
Yeah, thank you. Thank you for introductions. I'm Dushik Kong from Samsung Medical Center, Sungkyunkwan University, Seoul, Korea. I'm going to talk about the transorbital approaches, mainly focusing on the Meckel's cave and cavernous sinus area. And the major advantage of the transorbital approaches compared to the transcranial approaches, it can leave the, and it does not leave the outer bone defect, no temporal muscle atrophies. It just only leaves minimal scar and no craniotomy related pain, regardless of the tumor removal. To access the middle fossa meningioma cases, conventional transcranial approaches are lateral to the medial approaches. Instead of that, transorbital approaches can provide more anterior to posterior direction approaches, it can reduce the possible injury of the venous injury, and also it can minimize the retraction of the temporal lobe. And this principle can be applied to the same principles can be applied to the macroscapum and cavernous sinus area. Of course, endonasal approach is the best, wonderful approaches to access the paranasal sinus approaches, and also transorbital approaches can be an alternative treatment of the conventional approaches and endonasal approaches. The major concept is of the transorbital surgery is let's see the brain through the orbit, and we can access the temporal, frontal, ethmoidal sinus, and maxillary sinus. Finally, we can access the clinoidal segment of the brain, and then we can define the endonasal approaches can cover the whole paranasal space, including the infratemporal fossa area. Supraorbital approach is a wonderful approach to access sacral Willis and subfrontal area. But transorbital approaches can cover the middle cranial fossa and cavernous sinus areas. Conventional transcranial approaches, this is the pretemporal, transcavernous, transmacroscapum, transtentorial, transpituitary, so-called Dolan-Hakuba approaches can cover the whole cavernous sinus area and petrous apex regions. Compared to this one, Professor Kawase developed the anterior petrosal approaches more focusing on the petrous apex regions. And transorbital approach is more directed on the cavernous sinus area. This is the various kinds of the skin incision technique. And Alberto Di Somma described the level of difficulties of transorbital surgery according to the difficulties. And first, I'm gonna briefly talk about the middle fossa meningioma case. And these are all indications of the transorbital surgery. You can see the most tumors are located below the sphenoidal ridge, mainly focused on the temporal side. And we described the efficacy of the lateral orbital rim removal is very helpful, and compared to the without the removal of the orbital rim. And we described the sphenoorbital meningioma is a very good indications. Let's compare to the how to remove the lateral orbital rim. And left side is just only lateral orbital rim removers. The right side is, if needed, we can extend the superolateral orbital rim remover. And this is the meningioma cases. And after removal of the lateral orbital rim, finally we can fully expose the frontal temporal orbit at one surgical view. And finally we can access the clinoidal segment, the decompress the optic canals, decompress the orbit. At the same time, we can remove the frontal part, and finally we can achieve the gross near total resections. Some tumors within the cavernous sinus areas was left. Let me talk about the trigeminal schwannoma. Trigeminal schwannoma is a wonderful best indication of transorbital surgery because the axis of the tumor is almost parallel to the transorbital surgery. We analyzed our retrospective data in Korea. We analyzed 74 cases of the transorbital and endonasal cases. Most part can be treated with the transorbital surgery. We compared which one is the best one, and then middle fossa tumor, dumbbell type of tumor, is a very good indication of transorbital surgery. This is the major key consideration of the location of trigeminal lobe is very important things. And let me talk about the pituitary tumor. For pituitary tumors, we don't have to care about the trigeminal lobe or oculomotor nerve and fourth nerve because the whole tumor is located midline tumor. But let me talk about the trigeminal schwannoma. We have to know the location of trigeminal lobe preoperatively. Location of trigeminal lobe and the relationship of the brain tumor is very important to select the optimal approaches, endonasal, medial approaches, or lateral approaches. And then this is left side is okay, but right side is you cannot see. But we perform the tractography. Tractography shows the pathway of the trigeminal lobe. For these cases, maybe lateral approaches may be better, transorbital or conventional transorbital, conventional transcranial approaches. This is a real patient case, and we can preoperatively identify each cranial lobe, and then we can find the relationship between the tumor and view. This is endoscopic endonasal route. You can see the very limited surgical view. V1, we have to cross the carotid artery, and also we have to cross the trigeminal lobe. But transorbital view, we can avoid cross the carotid artery and also between the V1, V2, or V2, V3, and we can access the tumor involving the macroscapum and cavernous sinus area. These are the transcranial views, may be much better, but requiring the extended craniotomy. And this is the real operations. After incision of the skin, identify the greatest sphenoidal wing. First, we remove the lateral orbital rim. First, we medial part of the greatest sphenoidal wing removed and expose the temporalis muscle, and then remove the lateral orbital rim here. Just to take out the lateral orbital rim, you can expose the temporalis muscles here. Finally, we expose the greatest middle fossa dural, that is a middle cellular crest. Complete removal of cellular crest, and we can expose the whole anterior part of the temporal lobe. This is a lesser sphenoidal wing to expose the meningoorbital band. After coagulation and release of the meningoorbital band, we can detach the temporal lobe from the orbit, and then finally exposing the lateral cavernous sinus wall. We perform the interdural dissections, and the cavernous sinus was engulfed by the tumors already, and then you can identify the tumor capsule and incision of tumor capsule and debug the tumor. Finally, we can separate safely the tumors from the trigeminal root lead. And finally, this is porous trigeminus decompressing the tumor, debug the tumor. And finally, this is the posterior cisternal segment. And as much as possible, we detach the tumors from the whole brain stem. And finally, we could close it. This is a post-op MRI scans. And let me talk about the complications after transorbital surgery for trigeminal schwannoma. Of course, and sometimes the transient complications such as diplopia, partial transient ptosis, wound infections, but most the tumor complication is the tumor itself-related morbidities. Permanent diplopia and ptosis is very minimal. And in conclusion, I think that endoscopic transorbital surgery represents a favorable alternative approaches for the treatment of the trigeminal schwannoma and macroscapum tumors. And also, it can overcome some CSF leak after the transorbital surgery. And to do so, I think that transorbital approaches must be a good approaches. Thank you for hearing me.
Thank you so much, Dr. Kong. Wonderful presentation. So we will move to some question and cases as per format of this webinar. So I prepared some cases for you. Can you see the screen?
Yeah.
Can you see my screen? So we have like 20 minutes, more or less, to talk about some cases or other points. So let's start with this one, just to cover some of the topic that Dr. Mo show us. So this is a young lady with a history of headache, left ocular pain, and frontal osteoma. Very straightforward cases. And perhaps most of neurosurgeon or some of neurosurgeon will treat it with a bifrontal craniotomy to open up the frontal sinus, remove the posterior wall of the frontal sinus and cranial lights, and classic neurosurgery. So, but you show some very relevant cases of the possibility to treat via combined approach, endonasal, or transorbital alone. So, Dr. Mo, what you think about these cases? Would you treat in a combined multiportal fashion, only transorbital, superior eye leads? How to deal with this case?
So that's a great question, Alberto. There's a lot of tumor mass there. And so if you go transorbitally, it may be possible to get it all, but you're going to be working for a long time. That's just a lot of drilling. So from a practical point of view, I think a coronal approach is going to be helpful from above. You may also do an upper blepharoplasty approach from below, because one of the things that you have to think about is how you're going to manage the frontal sinus. You have to keep the orbital contents out of the frontal outflow tract after an operation like this. And so I like to put a sheet of PDS over the orbital roof defect, not because of pulsatile exophthalmos, but to maintain a drainage pathway.
Yeah.
And then the final thing is that you really have to think about the bone edges after after you remove the tumor, because if you have sharp bone edges adjacent to the dura, pulsations after a number of years are going to quite possibly lead to a frontal to a CSF leak.
Great. Dr. Kong, some idea what would you treat this
Oh,
osteoma, transorbital, transcranial?
yes, I have some experience of transorbital surgery for this tumor, but I found that it's very limited surgical view. So instead of using the transorbital view surgery, I favor to use the supraorbital approaches or bicoronal incision. Of course, bicoronal incision is too extensive approaches. We have to cut the hair. So instead of that, supraorbital approaches may be better. Remove the lateral orbital rim at the same time. Here it's combined the supraorbital and transorbital approaches.
Yeah, that's a good point, but how can you manage the frontal sinus in this case? Will you remove all the posterior wall of the frontal sinus, or you just remove the osteoma and reconstruct that?
In my surgical philosophies, a little bit some tumors are left because the osteoma is benign tumors. If possible, I would like to
Indeed.
treat the frontal sinus.
Okay, I
I'd
understand.
probably think
So when
about cranializing in this case posteriorly, just to be done with it, to make certain that it's not going to continue to enlarge. Although I agree with Dushek, leaving a little rim is probably okay.
it's okay. Okay, that's what we did together with our colleague NT to do a combined approach. We get through the nose and we get through the orbit, and we put fat graft to reconstruct it to isolate the frontal sinus here. The lady was quite good. We have like 3 years follow up, and the lady is happy with that. So I really don't know the answer for these cases. Actually, we do not have a lot of experience with this, but this case was good. So it was good to treat via a combined approach, but I think that the supraorbital approach it's also an option. But now I can ask another question about the reconstruction. So in our department, we use fat graft. And I know that Professor Kong, not always, no, but use fat graft. It depends on the cases. So the question is, how about the position of the eye at the end of the transorbital approach? How about enophthalmos or esophthalmos after transorbital surgery? And what about the rigid reconstruction versus fat graft? So if you want to comment on this, Professor Mo.
I think it is an absolutely beautiful job. I like to ask myself what I'm reconstructing. And so you don't need to reconstruct the orbital roof to prevent pulsatile exophthalmos. That goes away after 1 to 2 weeks, extremely rarely 6 months or so. But what you do need to do is to compartmentalize the sinus from the remaining sinus from the intracranial cavity, which you've done very nicely. And one of the things I like the most about it is if you see in the postoperative coronal view, you see that medial bone, the anterior cranial fossa going vertically, you have fat sitting over it. So there's kind of an edge to that bone, but the fat looks like it's protecting that edge from causing a future CSF leak. So I think you did beautifully, and you left the frontal outflow tract open below it.
Dr. Kong, reconstruction, fat graft versus other materials and position of the eye.
Yeah, I'm now considering how to reconstruct for these cases because the frontal orbital loop was fully exposed, and then maybe some risk of the pulsatile exophthalmos or eyeball, the pulsatile because of the brain pulsations. So I think that hard plate. When I open the orbital loop, I place the titanium plate or other alternative materials. Just place over the orbital loop, may be better.
Just the one consideration is if you put titanium plate over the orbital roof and you have dura on it, you have to be absolutely certain that that area is not exposed to the sinonasal cavity, because over time the pulsations of the dura on the titanium will erode through and cause a CSF leak. And so a PDS sheet is one nice thing that you can use to separate those contents, and it will dissolve over time. So that's what I use a lot in that area.
Yeah.
Okay, great. Go ahead. Dr. Kong already showed a lot of cases of trigeminal schwannoma. There is also a lot of many other techniques. I will skip all the part of the video. Just once again, I would like to stress the concept of the reconstruction. So in this case, at the end of reconstruction, you see the brainstem here, you see the lateral wall cavernous sinus, and I have some pneumatization of the petrous bone here. So I put fat graft, and I love to use fat graft. I put fat graft all in the cavity, all in the surgical cavity, and also on the orbit cavity to prevent what it is the also the enophthalmos. So I would like to know, Dr. Kong, what's your experience on this? Once again, the question about reconstruction that really worried me. Even if the CSF leak rate is very low in transorbital surgery, we need to know the position of the eye at the end and at the follow-up. So what's your experience about that?
Yeah, thank you for great questions. I think the total incidence of CSF leak after transorbital approaches is known to be about 3% of the whole cases. And
3 or 4, yeah.
most cases are from after the removal of the meningioma cases. For my cases, transorbital surgery, of course, and fat graft material is one best good treatment modalities, reconstruction techniques. But for me, I have never experienced about CSF leak after removal of trigeminal schwannoma, because Meckel's cavum and cavernous sinus area is not directly connecting to the intradural space, and also sometimes posterior cranial opening can be connected to the cavernous sinus root, but it's very long. Just place the collagen matrix such as duragen was enough. So for me, I do not use the fat graft materials, but it depends on the surgeon's preference, I think.
Okay, so this for the side of CSF leak prevention. For the sides of enophthalmos, you know, I'm very worried about that. When I remove a lot of bone inside the orbit cavity, I'm worried about as neurosurgeons. I don't know if Chris Moore wanna comment about that, but I'm worried about, okay, the eye will be in an ophthalmo position in 2 years. So I
Yeah,
put
So I think
fat graft and please.
so I have experienced of 2 cases of enophthalmos after operations. One case was middle fossa meningioma case, and the other case was trauma case. We combined the endonasal and transorbital approaches. There was no bony structures resisting the orbital structure. But after removal of the trigeminal schwannoma, I have no experience. Still
No, it's
now following over 5 years, I think that you don't have to worry about that.
So I have a case of enophthalmos from removing the greater wing of the sphenoid for a metastatic tumor, and it manifests just as a reduced vertical fissure. So the distance between the upper and lower eyelids decreases, and the patient just looks like their eye is smaller. And so depending on the situation, I will, excuse me, if I have a large bone defect, I may put fat in there. But the key thing to realize in surgery like this, at the end of the operation, the patient is going to have quite a bit of orbital edema. And so we measured the globe position with an exophthalmometer on the table. And we found that when a patient had 2 to 3 millimeters of proptosis, they ended up in excellent symmetry. So you don't want the patient to have exact symmetry at the end of the operation, or they're going to have enophthalmos. So kind of a nice little trick is to do exophthalmometry intraoperatively, and your ophthalmologist can teach you how to do that.
Yeah. It's a good point. Okay. So we have, I think, 7 minutes, and I have another great cases. So anterior clinoids. Anterior clinoid, it's quite good. It's a it's a good view from the transorbital perspective. I have these cases, this classification I found in the literature is quite interesting. So for this case, Dr. Kong, you would like to go transorbital, would like to go supraorbital. Now the main controversy or critics that we may receive if we go ventrally, that you control optic nerve and carotid artery at the end of the surgical procedure, while if you come from the supraorbital approach, you just left the frontal lobe and you get to the carotid and optic, and then you have the tumor. So does size matters? In this case, I did it transorbital because I think it's quite a small tumor, I can get it, but for a large one, I'm not so sure. What's your opinion about that?
Yeah, it's so nice, beautiful 3D reconstruction. And
Thank you.
according to the beautiful 3D reconstructions, I think the tumor is compressed the optic nerve at the level of the optic canal. And
Correct.
we have to decide the clinoidectomy is necessary or not. I think that if you wanna decompress the optic canals completely, and we have to do the anterior clinoidectomy. But if you don't decide to the clinoidectomy, supraorbital approach is okay. But if you wanna, I think that if I were used, I will do the clinoidectomy to completely remove or decompress the optic canal. And to do so, I think the transorbital approach is a very, very good options to achieve this goal. Did you do the transorbital surgery? Of course.
Yeah, I did yeah, I did transorbital. That's the anterior clinoid. I just left the tip of the anterior clinoid. I get down here. That's the optic canal. As you can see, I will skip driving the video. I get to the inferior part of the tumor. You just open up the dura and you have the tumor in front. But yes, the problem is, okay, you have the tumor in front, and you cannot see and control the carotid artery that is posteriorly to the tumor. But it's quite the same from a tuberculum cell meningioma that you treated through the nose. It's exactly the same. So okay, in this case, I agree with my decision, but what if it's a large tumor, and what if the extension is a little bit over the planum also? Are you able to reach through a transorbital approach?
Yeah, the tumor is extended to the planum part, of course, and we have to combine maybe supraorbital or open transcranial approaches may be better. But a little bit small size tumors, just compressing the optic canal, a little bit more bigger one, and tumor looks soft, and I think the transorbital approach is still good indications and good surgical approaches. I think tumor is very hard, and then it's not good indications. This is the best indication of transorbital surgeries.
Yeah, we did it. That's a fat graph reabsorbers 1 year and a half. The skin incision is completely hidden, so it's quite good. Any comment, Dr. Mo, on this?
It's a beautiful result, as all of your cases seem to be. That's
Thank
great.
you.
Nice job.
You are the
So
best.
let's go. Oh, thank you. So let's go ahead with the last topic. So I don't know if we have 4 minutes or less, but I would like if you, Dr. Kong, would like to comment on this. Not so young lady, history of seizure that sent us from neurologist, a tumor in the right amygdala. I think this was our third or fourth cases that we treated through the orbit, and I think it's a good way to get it transorbital. Why, Dr. Kong? It's a good reason to get it transorbital in this case.
Yeah, the surgical corridor to access this medial temporal lobe, the tumors involving the medial temporal uncus and amygdala and some part of the anterior part of the hippocampus. And then surgical corridor of transorbital approaches is almost directed to the medial temporal lobe. And after decompressing opening the greater sphenoidal wing, and then open the dura, we first identify the cortical and sulcus, and then under the navigations, we can access the medial temporal uncus. Yes, that is tentoriums. After removal of the
Correct.
we can access the amygdala and hippocampus, and you can find the PCA and choroid artery.
Third cranial nerve.
Wonderful, wonderful surgical view. And you identify the hippocampal artery from the choroid artery, and noticing the tentorium edge, and you can find the false nerve sometimes, and exposing the full perimesencephalate systems. Wonderful, wonderful technique. I cannot do.
Yeah, yeah. We have a good result in this lady. She's seizure free. She's happy, and this is the final result. So it was a DNET tumor, so she was cured. So with this, I don't know if we have more time or not, or if you want to comment something more. I think we are. If Tim or Paul is over there, we have more minutes, or we should stop the webinar.
Nobody's here.
No,
Why don't we
nobody's
do
here.
one more? Why don't we do one more quickly?
No, just we probably we can make the conclusion on this. So we have talked about a lot of possibility. I don't know if we missed something. We talked about sphenoorbital meningioma, corporate sphenoid wing meningioma, cavernous sinus, Meckel cave, frontal sinus, intra-axial pathology. We talk about CSF leak. We talk about position of the eye. Any other complication which in our experience the complication rate is very low, but what is really missing, I think it's comparative studies with a matched control cohort with transcranial approaches. I think it's really missing in the literature. It's very difficult to do that. There is a wonderful paper by Walter Jean now in the literature about minimal invasive surgery, not only transorbital, and I think that this could be probably the next effort by all of us to make cases together, to match them, and try to understand advantage and limitation comparing different techniques.
Yeah.
Do you agree?
Yes, I agree to your opinions. If we compare each treatment modality for the small sized tumors, less than 3 centimeters, it will be comparable to do so. But most cases, the indication of transcranial approach is very big sized tumors. We cannot compare the transorbital approaches. But I think the small sized tumor is okay to compare each treatment modality. Endonasal, transorbital, or anterior it's okay. Good.
Yeah. Okay, that's 40 minutes. I don't know if we can talk for hours.
Yeah, no, that's perfect. That's fantastic. I really appreciate it. I think there's, one of the critical things perhaps to address, and I apologize if this was brought up, but, maybe if you could talk just very briefly about how people should start, what kind of cases they should start with, and what are the sort of cases that are maybe the most advanced that even you struggle with, just to give people a little bit of an idea about how to start venturing into this, and then we'll call it quits.
Thank you for this question. Dos, please.
For me, and the first case was the frontal osteoma. I was very embarrassed because the frontal osteoma is benign tumors, very difficult to remove totally through the transorbital view. So I think that if you accumulate some cases, it's possible techniques, but to do before first starting the apply to the frontal osteoma, I think then most easy indication is the sphenoorbital meningioma is best indications, and also you can do the mastering the surgical procedures, and then next move to the Meckel's cave and cavernous sinus area.
Chris, from your perspective?
I agree completely. Alberto led a group putting together a sort of a ladder in terms of complexity of degrees of difficulty, and Dushik showed that very nicely. And I think that's really important. A key thing is these things are quite different from what most people are trained in. There's really no specialty that just does these surgeries, and it's usually teamwork. And so I think it's important when people are starting out to go to a course And these courses are usually hands-on dissection courses with great discussions, and they last 2 to 3 days. Many of these courses are listed at the endoorbit.com website, so that's a good thing. But I think it's great to learn as a team, work together, and definitely start simple.
Great resources, and thank you, Alberto. Thank you, Chris. Thank you, Dusik, for all of your time and effort put in teaching all of this about this. And we look forward to seeing everyone again next month for the next session on endoscopy and neurosurgery. Everyone have a good evening, morning, etc.
Thank you.
Thank you.
Thank you so much.